Hello, and welcome to the topic Paget's disease in the module Rheumatology. By the end of this topic, you should be able to define Paget's disease, explain the pathophysiology of Paget's disease, outline the causes of Paget's disease, outline the classification of this disease, describe the clinical manifestations, outline the investigations, discuss the principles of management, and finally discuss the complications and prognosis of Paget's disease of the bone. Let's get started. Paget's disease, also known as osteitis deformans, is a progressive localized bone remodeling disorder characterized by increased bone turnover. Normal lamellar bone is replaced by weak woven bone, leading to localized pain and bony deformities such as bowing of the long bones and possible skull deformities. The pathophysiology of Paget's disease mainly revolves around increased bone remodeling, and it is estimated to be roughly 20 times the normal rate. This elevated remodeling activity is attributed to the increased RANKL rank activity, which increases NFKB signaling, ultimately promoting bone resorption by osteoclasts. Moreover, there is increased osteoblastic activity, which results in the formation of disorganized woven bone. The remodeled bone is more vascular and lacks strength, causing it to be easily deformed by stress and are highly susceptible to fractures. Occasionally, the remodeled bone is enlarged, and this causes entrapment neuropathies, especially when this occurs where nerve passes through the bony tunnels, for example, at cranial nerve canals, skull base foramina, and the spinal canal. The most commonly affected sites are the pelvis, skull, vertebral column, long bones, and lower extremities. In roughly a third of patients, the disease is monostotic. In the remaining two-thirds of the patient, the disease is polyostotic. The main feature of Paget's disease is localized areas of hypermetabolic bone, though there are three distinct phases that the disease evolves through, followed by a quiescent stage. First, an initial short-lived lytic phase where there is marked increase in osteoclastic activity causing bone resorption. Then, a mixed phase of lytic and blastic phase where there is increased levels of bone turnover. The increased osteoclastic activity is accompanied by an increase in osteoblasts, though new bone formation is with a haphazard layout of collagen fibers, which forms abnormal hypervascular woven bone. In the sclerotic phase, bone formation outweighs bone resorption, and this leads to the formation of dense sclerotic bone. Finally, in the quiescent stage, both osteoclastic and osteoblastic activity ceases. The exact etiology of Paget's disease is unknown, though several risk factors have been suggested. A family history of Paget's disease or genetic factors have been suggested. There have been familial clusters. Infection by measles virus, respiratory syncytial virus have been implicated in the development of Paget's disease. Environmental factors also have been hypothesized to contribute to the pathogenesis of Paget's disease. High levels of arsenic and contact with cattle or pets may be contributing factors. Paget's disease is most commonly classified according to the degree of bone involvement. Monostotic bony involvement means that only one bone is affected, most commonly the femur. Polyostotic disease, more common, it involves more than one bone and usually affects the femur, pelvis, skull, or tibia. Otherwise, Paget's disease could be also classified according to the severity of symptoms, either asymptomatic or symptomatic. Most patients with Paget's disease are asymptomatic. Symptomatic patients may experience symptoms that range widely in terms of severity, from minimal bone discomfort to severe pain due to pathological fractures. Sometimes, they may present with complications such as secondary osteoarthritis, spinal stenosis, deafness, or other nerve compressive syndromes, and rarely high-output cardiac failure. Again, the majority, approximately 70 to 90% of patients with Paget's disease are asymptomatic. Many are even misdiagnosed with another musculoskeletal disorder. Diagnosis is often incidental on imaging when patients are being worked up for other diagnoses and is further clarified on lab results. Symptoms that are commonly reported include bone pain associated with erythema and temperature on skin surrounding the affected bones, problems with chewing or loose teeth, facial changes, symptoms of cranial nerve deficits, impaired hearing, and headaches. Clinical signs of Paget's disease include pathological fractures such as chalk-stick fractures of long bones, bony deformities such as saber shin, skull involvement such as skull enlargement, frontal bossing, prognathism, and leonine facies, neurological deficits such as cranial nerve deficits and impaired hearing, and some may present with cauda equina syndrome or nerve root compression. Moving on, the first investigations to order include plain X-rays, total serum alkaline phosphatase, bone-specific alkaline phosphatase, serum calcium, serum pro-collagen 1 N-terminal peptide, serum C-terminal pro-peptide of type 1 collagen, liver function tests, and serum 25-hydroxyvitamin D. Lab tests done in Paget's disease include blood work and urinalysis. Blood work typically reveals normal calcium, phosphate, and parathyroid levels. A secondary increase in parathyroid level is observed in a subset of patients due to increased calcium demand from elevated bone turnover rate. On the other hand, hypercalcemia and hypercalciuria may develop as a result of immobilization. Serum ALP, a marker of osteoblastic activity, may be normal or elevated. Bone-specific ALP is the most sensitive blood test for diagnosis and can be used as an index for treatment response. ALP is utilized to track response to therapy, and bone-specific ALP can be utilized if available. On plain X-rays, in the early stages, it will show lytic changes, common in the skull, advancing V-shaped lesions in long bones, and incomplete fractures. In its later stage of disease, a sclerotic picture dominates. Besides that, there may be thickened cortical bone with coarsened trabeculae, expansion or enlargement of a region of a bone. On skull X-ray, there may be thickening on the diploi and osteoporosis circumscripta, which results in a cotton wool appearance. Vertebral X-ray may reveal thickening of the upper-lower plates of the vertebral body, leading to a picture frame appearance and diffuse enlargement of the vertebrae, seen as ivory vertebra. Pelvic X-ray may show disruption or fusion of sacroiliac joints and Brim sign, and this happens due to the thickening of the iliopectineal line. Additional modalities to consider include CT scans and MRIs. Pagetoid bone appear capacious and disorganized here. Bone scintigraphy should be done at baseline to determine the extent of bone involvement and later on as disease monitoring. Treatment mainly focuses on halting excessive osteoclastic activity, hence reducing bone turnover and allowing for normalization of bone formation. Treatment is also mainly indicated for symptomatic patients and patients with a high risk of developing complications. By aiming to normalize metabolic activity to normal, subsequent treatment is based on controlling symptoms and bringing non-specific markers back to normal parameters. First-line drugs used in Paget's disease are bisphosphonates, which induces apoptosis of osteoclasts. Examples of oral bisphosphonates are telodronate, alendronate, and risedronate. Frequent use of high-dose bisphosphonate is associated with gastrointestinal side effects and should be used in caution when patients have a history of gastrointestinal reflux disease. IV bisphosphonates include zolendronate and pamidronate. Second-line drugs are calcitonin, which are less effective as compared to bisphosphonates and are indicated in bisphosphonate intolerance or when bisphosphonate use are contraindicated. It is administered via a subcutaneous injection and has been shown to partially heal lytic lesion in Paget's disease but rarely normalizes bone turnover. Adverse effects commonly reported are facial flushing, nausea, and tachyphylaxis. Supportive drugs include vitamin D3, also known as cholecalciferol, calcium, and NSAIDs. Calcium and vitamin D levels should be normalized prior to treatment as to prevent hypocalcemia, while NSAIDs are prescribed for pain management. Surgical management is only indicated when there is bone deformity and pathological fractures, which is then requiring reduction and fixation, especially for femoral fractures. Patients should be educated about high-risk activities and physiotherapy to promote range of motion, muscular strength, and ambulation skills. When long bone deformities occur, orthosis can be included as part of therapy, including training to use walking aids. Hearing aids are also recommended at an early stage due to the progressive nature of the disease. Complications include exacerbation of localized pain when initiating therapy, pathological fractures, development of hydrocephalus, kidney stones, esophagitis with bisphosphonate use, excessive bleeding, and heterotrophic ossification. Rarely, in less than 1%, there is malignant transformation into osteosarcoma or high output cardiac failure. That is very rare, but usually associated with high disease activity and extensive skeletal involvement. The prognosis is generally good, but this varies between individuals. Treatment is able to control disease and may induce remission for a period of time. However, this is not curative and disease may become active again. A good prognostic factor is being treated before any significant complications occur. On the flip side, a bad prognostic factor is when osteosarcoma develops. Let's summarize. Paget's disease of the bone is characterized. Let's summarize. Paget's disease of the bone is characterized by increased bone turnover and replacement of normal bone by weaker bone. Paget's disease of the bone is a chronic bone remodeling disorder. A high rate of bone remodeling driven by excessive osteoclast and osteoblast activity results in the formation of disorganized woven bone that is weaker than a normal bone. The exact etiology is unknown, but genetics, infection, and environmental factors have been hypothesized. Most patients are asymptomatic, but the most common complaint is bone pain or discomfort in the affected area. Some may present with pathological fractures and other complications due to disease progression. Diagnosis is often incidental on imaging on patients being worked up for other diagnoses. Definitive diagnosis is clarified with matching findings on plain film X-rays and lab results. Consider Paget's disease in older patients with elevated ALP but normal GGT levels. The main aim of medical therapy is to suppress osteoclastic activity, to halt disease progression and complications. Surgery is only indicated where there are pathological fractures or bone deformities. We have come to the end of this topic. Thank you.